Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has two companion published articles, number 24 and number 25. Welcome to the Pain is Not the Only Problem podcast. Article 24, Pain is Not the Only Problem, Advanced Imaging Part 1. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. Advanced imaging is the prevailing scientific evidence that has a power like no other form of diagnostic importance. It is complex, impressive, imposing, and definitive within the medical culture. But advanced imaging is also elusive, contingent, relative, imperfect, and its diagnostic value is not well understood. If you have a science that is not well understood, then that science becomes like magic. It gets the power that magic has and can become dangerous to the diagnosis and to the patient. It becomes dangerous because it asserts too much influence, sometimes being the only evidence while ignoring other valuable clinical evidence. According to Whittier et al. 2017, although imaging technology has advanced significantly since the work of Garland in 1949, interpretive errors remain unchanged. Medical error is the third most common cause of death in the United States. Error in diagnostic interpretation is an unfortunate and common occurrence exacerbated by the increased demands placed on radiologists. 1 billion radiographic examinations are performed worldwide annually, and with a 4% error rate translates into approximately 40 million interpretive errors per year. Advanced imaging requires interpretation, detection by visually scanning for conspicuous lesions. Interpretation is not factual. It is a stylistic attempt to explain anatomy from a picture. Interpretation, like all aspects of medicine, has errors of omission and errors of commission. Errors of omission involve non-included information, absent data, or describe inaction, while errors of commission involve included information, extra or presented data, and added or extra actions. Errors in interpretive omission can occur when the wrong view is taken or taken incorrectly, when necessary imaging is not performed, when the interpretation is hasty, causing perceptual and recognition errors, and when the interpreter's opinions or biases influence the report. Errors of omission can occur when the radiologist habitually looks for certain findings. A low back pain study might cue the radiologist to look for disc herniation or nerve encroachment, but might oversight muscle wasting and fatty replacement. Errors of interpretive commission can occur when incidental findings suggest unexpected disease or lesion, or when findings are interpreted to diagnose by speculation or personal bias, or imaging is used to hunt for a diagnosis. Errors of commission can occur when the radiologist reports features to support a wrong diagnosis. Interpretation is an attempt to explain anatomy from a picture. Interpretation cannot demonstrate the patient's function or the patient's pain. A picture of a cell phone can't demonstrate its ability to ring or get a signal. After all, it's just a picture. Interpretation should demonstrate reversibility. If the study findings are interpreted to explain a diagnostic cause for the patient's symptoms, then the patients with those same symptoms should demonstrate the same study findings in their interpreted views. According to Moyer et al. 2016, faulty interpretation reports can occur for several reasons. Since radiologists commonly use dictation to report their findings, there can be up to 10% errors due to voice recognition inconsistencies. According to Ringler et al. 2015, speech recognition software has many benefits, but also increase the frequency of errors in radiology reports, which could impact patient care. 1.9% contain material errors. According to Waite et al. 2017, which discusses interpretive errors, scene processing errors, recognition errors, inattention blindness, satisfaction of search, and conditions of low prevalence. Let's look at these. Interpretive or perception errors occur. Features are not detected because they are not sufficiently conspicuous, are subtle of small size, without defined borders, insufficient contrast, for example. However, scene processing errors occur due to insufficient fixation of the central vision and of peripheral vision. Features are tested against the cognitive schema or long-term memory of the radiologist to determine whether a feature is suspicious. Recognition errors occur because too little time is spent on a feature. Time on a feature is called dwell time, and the dwell time is insufficient to positively identify features. The researcher has a representation of target items in mind that have those features and directs attention to those findings or looks for those findings that has those features. Image inspection may not include the entire field, only the field where those certain features likely reside. Inattention blindness has been implicated in 60% of radiologists who fail to report a missing clavicle. Satisfaction of search is the discontinuation of a visual search once the radiologist finds an abnormal feature or abnormal features and becomes satisfied with the meaning of the image. In conditions of low prevalence, radiologists are more likely to reject ambiguous findings and terminate a search more quickly. Do your ABCS scanning techniques assess the entire image, or did you look only for that damning evidence that you gravitate to? Do you point your pencil eraser at the degenerative changes and reflexively blame it for the patient's symptoms? Do you base all of your treatment plan on the image? According to Lee et al. 2015, abnormal findings in 67% of asymptomatic patients evaluated by MRI. After 4 years of observation, 70% untreated remained unchanged, 15% improved, and 15% worse. According to Anderson 2011, with regard to the short-term and long-term improvements in pain, short-term being less than 3 months, long-term being between 6 and 12 months, no differences were noted between routine, immediate lumbar imaging, and usual clinical care without immediate imaging. MRI did not provide any additive value over clinical assessment. MRI does not seem to have a measurable value with respect to planning conservative care. Imaging techniques exposes the risk of labeling a patient with a pathoanatomic diagnosis unrelated to the actual cause of the symptoms. What do you say to the patient who asks you, "Doctor, how many people my age have the same MRI but never have any low back pain symptoms?" Or, "Doctor, describe the scope of the contributors to my low back pain symptoms as you see it, besides the MRI." Could you diagnose and treat your low back pain patients just the same without any imaging? There are many important organic contributors to low back pain that cannot be seen on advanced imaging. For example, the complete patient history that is responsible for at least 90% of the diagnosis, especially when the entire problem list is considered. Central processing that manages ADLs, sport maneuvers, stances, and postures, range of motion, motor sequencing, core recruitment, cannot be seen on advanced imaging. Muscle tension time relationships, fatigue, muscle weakness, stiff joints, faulty movement patterns, VO2 max, reaction time, endurance, and gait cannot be seen on advanced imaging. Hormone balance, adrenal stress, energy metabolism and delivery, work recovery cannot be seen on advanced imaging. Blood chemistry, vitamin deficiencies, effects of medication, appetite, and diet cannot be seen on advanced imaging. Bowel and bladder function or urgency cannot be seen on advanced imaging. Depth of breath and lung capacity, ability to uptake and deliver cellular oxygen cannot be seen on advanced imaging. Contribution to the horseshoe to spinal stabilization, or spinal stabilization on its own for that matter, cannot be seen on advanced imaging. Types and condition of their shoes, their foot placement, whether they wear tight underwear, carrying a baby on their hip, cannot be seen on advanced imaging. Also, pain, numbness, tingling, radiculopathy, sensory loss, and tremor cannot be seen on advanced imaging. Interruption in nerve conduction, headache, sightedness, balance, and attention cannot be seen on advanced imaging. Sleep quality, sleep duration, sleeping position, quality of mattress cannot be seen on advanced imaging. Social acceptance, occupational satisfaction, patient education cannot be seen on advanced imaging. Smoking, alcoholism, and gut dysbiosis cannot be seen on advanced imaging. Sagittality cannot be seen on advanced imaging. The list of quality of life contributors that can be seen on advanced imaging are 0. The value of advanced imaging is currently under review. Does it have value in the non-traumatic low back pain clinician's office as a first line in case management when it can never explain pain? A second think on advanced imaging might be prudent, since pain is not the only problem. And now on to Article 25. Pain is not the only problem. Advanced imaging, Part 2. Diagnostic completeness is described as the patient's diligence to highest standard of professionalism, a duty to completeness and excellence in medicine with cross-culture respect. Waite et al. 2016 recommends 4 non-technological solutions to reduce interpreter error. Number 1, optimize their experience by offering ergonomic features, enhanced lighting, breaks, naps, and social interaction. 2, reducing uninformative interruptions that occur during error-prone scenarios. Number 3, double reading benefits to accuracy and completeness, and methods to reconcile discrepancies between readers. And 4, non-punitive approaches to performance improvement, self-disclosure of mistakes. There are many important organic low back pain findings that can be seen on advanced imaging. These findings may seem novel, however, I would argue strongly for their interpretation and representation in a low back pain report. Number 1, fatty replacement. Fatty replacement represents an infiltration of fat marbling within the muscle belly. Fatty replacement is an excellent indicator of a muscle use change from stronger to weaker, for example, in the spinal lumbar erectors. Number 2, thickening of non-contractile tissues. Thickening of non-contractile tissues indicates an increasing reliance on hard tissue, such as ligament and tendon, to provide structural tension and trussing in the absence of spinal stability or muscle belly diameter. Number 3, flattening of a muscle related to density. Flattening of a muscle indicates muscle bellies at high tension, not to be confused with number 4, diametric reduction of muscles, indicating weakness, underdeveloped muscle bellies, even in adult athlete patients, notably at the psoas and abdominal walls. Low back pain studies should include the surrounding core musculature to include the transversus, respiratory diaphragm, and pelvic floor. Classical advanced imaging interpretations includes the usual organic low back pain suspects. However, in this list, I have omitted disc herniation classifications and spinal cord impingement due to the lack of scientific evidence. Instead, the list includes primarily contributors to root imbrication, instability, alignment, and inflammation. And here they are. Number 1, thickening of the corpora transverse ligament, possibly contributing to nerve root imbrication. Number 2, densification of the spinal and lumbosacral ligaments. Number 3, measurements of the spinal curvatures and vertebral alignment that are a result of and contribute specifically to spinal instability as previously defined. Number 4, high signal or cell signs, etc., indicating inflammation and swelling. Number 5, IVF encroachment factors such as fat, bone, nerve, inflammation, or tumor. And 6, cord pathology, including tethered cord, Chiari malformation, and quadratus syndrome. Anderson 2008 brings us this. Help patients understand the current evidence about the limited value of immediate imaging in cases involving nonspecific low back pain. In a case study, we have a 22-year-old female right-handed collegiate soccer player that plays the wing-back defender, and she is complaining of nonspecific low back pain when she traps a ball with her left foot and right shin pain related to a traumatic injury since a game 3 days ago. What questions would you ask? What would you know about the demands of her position as a wing-back defender and how it might contribute to the diagnosis? Wikipedia wing-back defender with 60 citations, viewed April 30th, 2019. A wing-back defender is one of the most physically demanding, more often adventurous, and expected to provide width and need to be of exceptional stamina to be able to defend against opponents' attacks down the flanks. Consider the demand of aggressive lateral leg work and likelihood of blunt force contact, the sudden decision-making, and autonomics required to steer her body athletically through the game beginning to end. Playtime goes until a foul is called or a goal is made. She is an inspired young athlete willing to deal with the demands of the sport, obviously, since she did not choose archery. Is she pushing through pain? Does her coach allow her to push through pain? What kind of in-house therapies does she get? Are they working? What is her training and recovery experience? What is her nutrition like? Is she injured often? Is it the same injury? Is she left or right-footed? Is she watching videos of her practice and game time? None of the aforementioned points can be seen or answered using advanced imaging. It is a gross negligence and unprofessional medicine to simply aim the patient toward imaging without genuinely learning about the patient and their values and learning about her specific impeded sport or skill. What is your diagnosis? The purpose of this imaginary case study is to exemplify the prevailing low back pain patient and athlete in the clinical setting. Nonspecific low back pain with other presenting symptoms, whether related or not, and an inability to perform certain skills or duties with or without pain, and with other pain-free performance limitations with no complaint. Therefore, a robust conversation with the patient athlete is in order. In my office, we use soccer balls, volleyballs, tennis rackets, golf clubs, baseballs, softballs, to get a better sense of the patient's functional and symptomatic mechanics. We review videos together of their performance. We screen share up on a 75-inch TV in the clinic. Or we watch YouTube videos that I've made. Or we watch YouTube videos that they've made. Or I meet them at a tennis court, at a track, or on a field. Detailed attention to patient specificity has been lost in the field of medicine. It has been diluted down to the sweep of a pen or an imaging order. Old habits are just that, old and habits. Maybe we need to take another look at the science and ourselves. Isn't it easy to agree that pain is not the only problem? Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.